Okay, now let us have another class of diabetes, and this time we are looking at the acute complications of diabetes, their pathophysiology, their clinical features, and how to manage them. These ones are encountered by so many practitioners in the consulting room, at home, in the wards, in the outpatients, so that they can be able to equip themselves on ways to deal with these diabetic emergencies. So first of all, let us start by discussing about diabetes. What is diabetes? Diabetes is a group of metabolic diseases characterized by a chronic hypoglycemia with a disturbance in the carbohydrate, fat, and protein metabolism, which results from a defect in insulin excretions, insulin actions, or both. So that is the definition of diabetes. Now, as we continue, now let us look at the normal way the glucose is metabolized and the fat is metabolized, so that you can be able to understand the abnormal way of glucose metabolism and fat metabolism in absence or in reduced insulin. So let us start with this normal one. So it starts with what? You take your food, the food goes to the GIT. In the GIT, the proteins in the GIT are absorbed in the villi, and then these proteins, in terms of amino acids, they are transported in the blood, and then they are taken to the liver. They are taken to the liver. Then you take glucose absorbed from the GIT, it goes to the blood. In the blood, the glucose can either be taken to the muscles where it is converted, oxidation takes place in the mitochondria, and it is utilized to or stored there or converted into energy at the mitochondria. Again, this glucose again can be taken by the adipose tissues, oxidized, and then there is oxidation in the adipose tissues and stored there. Then it can also go to the pancreas beta cells, where it stimulates insulin production, production. Now, remember again, in the tissues, in the muscles, the glucose is oxidized again and can be converted into what? Can be converted into lactic, puritic, and then goes back to the liver for storage, and then goes to the liver. In case there is production of acid, then it can go to the liver, which can initiate the process of glucogenesis. And this glucogenesis results a conversion of to glucose by the aid of glycogen, and these glucoses can be oxidized, and also that means now that the liver starts producing glucose. You can see again that in the liver, free fatty acids from the adipose tissues and the glycerol can be converted into ketones bodies by the ketogenesis, and also can be oxidized to glucose, which goes to the blood circulation, stimulates the beta cells to produce insulin. So you can see again the amino acids from the glucose can be also proteolized into what? Into glucogenesis back in the liver. So basically, that is the cycle of glucose metabolism and fat metabolism in the body. The involvement of the gut, the involvement of the muscles, which consume the glucose, on the fatty acids for the purpose of the protein, and the liver. You can see how this one is moving around. Now, how does it happen if there is not enough insulin, or there is insulin resistance in terms of metabolism of these fats and this glucose. You take food, there is amino acids in the stomach, in the blood circulation, and these amino acids, since there is no insulin, or there is vessel insulin, there is increase of amino acids because there is no uptake of amino acids to the liver. There's not enough uptake of the to the liver. So again, when you take glucose, there is glucose increases the blood circulation because there is not enough insulin. Again, this one, because the insulin, there is not enough insulin, there is no uptake of glucose by what? By muscles, tissues, for the conversion into energy, or to be stored, or for oxidation, and then stored, and then formation of what? The small glucose in the tissues can be converted into lactic plate, which can result to lactic acidosis. And then in the liver, you can see that if there is not enough glucose, then there is increased glucogenesis, there is increased glucose because of oxidation of free fatty acids and the ketones resulting to the ketones in the body, and this ketones is what causes ketoacidosis. Because there is no insulin, there is increased fatty acid and glycerol because of free fatty acids and glycerin synthesis by the glycerin synthesis in the adipose tissues. So you can see that the relationship between a normal glucose and fat metabolism, and the abnormal glucose metabolism when there's insufficient insulin in the body. Now, let us see the clinical features of diabetes due to lack of insulin. How does these clinical features comes about? How does your patient manifest, and why is each and every manifestation lacks? Now, in this syndrome or a graph representation, you'll see that a patient does not have enough insulin. Now, if the patient does not have enough insulin, what will happen? There is increased excretion of glucagon, cortical hormone, growth hormone, and catecholamines. These ones are the hormones which work against insulin, the antagonist insulin. So if these ones are produced, they lead to what? They lead to decreased anabolism, they lead to decreased anabolism, and also they lead to increased catabolism. They also lead to increased catabolism. So what happens if there is an increase in catabolism? If there is an increase in catabolism, means that there is glucogenesis increases. The liver starts stimulating the process of glucogenesis, just that there is the stored glucose start now being converted so that it is mobilized in the muscles, and protein is broken down. This one, glucogenesis now, because the muscles start broken down to produce energy, then the patient start wasting, and this is the reason why patients who have patient who have insulin, lack of insulin because of diabetes, they are wasting, and sometimes it is called metabolic a syndrome. Sometimes it can be metabolic syndrome. It can result to also what is called a metabolic cachexia. Because of increased catabolism, which result to increased breakdown of lipids, which is called lipolysis, there is loss of weight. There is loss of weight. This breakdown of lipids can result to either polyphagia, decrease in leptin, polyphagia, or hyperketonuria. There is increased production of ketones, and this one like acetoacetate and butyl and acetone. This one is because of that, and this one hyperketonuria result to acidosis. And when the patient has acidosis, this one the patient will manifest with hyperventilation because of acetone, acetoacetate, and butyl. So there is a peripheral dilatation, vasodilatations because of acidosis, And these peripheral dilatations result to hypotension. So patient resort to hypotension, hypothermia, which is because of lactic acidosis. So the patient lowers pressure and lowers temperatures and this hypotension results to lactic acidosis. So in this case now, the patient is having diabetic ketoacidosis, and diabetic ketoacidosis can lead to death. Now, on the other side, you'll see that there is a decreased anabolism, and this one results to hyperglycemia. If there is increased hyperglycemia, the patient will feel fatigue, and when you test the sugars, it will be high. And this one leads to starvation in the midst of the plenty. There is starvation in the midst of the plenty. So this one, hyperglycemia, results to glycosuria. There is a lot of glucose in the urine. These ones result to urinary tract infection like variolitis, balanitis, because of this glucose in the urine. The number of flora in the vagina, in the penis, all these ones, they will now start taking this glucose and multiplying. And when they start multiplying, they also start destroying the tissues around that area. Now, glycosuria on the other side can result at osmotic diuresis because the body will need a lot of water to clear out these sugars. So there is osmotic diuresis, which will result to polyuria and polydipsia. The polyuria and polydipsia, and this one will result to what? To electrolyte imbalance, resulting to salt and water depression, especially sodium, and this one can result to tachycardia. And tachycardia and also can result to hypertension. Again, can result to lactic acidosis. And there is this one result to hyperosmolar hyperglycemia syndrome. So this one result to death. So in this case now, you can see that there are two pathways the way the symptoms of a lack of insulin are manifested: through the pathway of decreased anabolism and through the pathways of increased catabolism. And all of them, they end up having lactic acidosis, and also the decreased anabolism can result to hyperosmolar hyperglycemia syndrome, and all of them result to death. Now, let us see in simple, how does insulin work? It works in two ways. It either stops or promotes. What does it promote? Glucose promote uptake of insulin promote uptake of glucose in the muscles and adipose tissues. It promotes glycolysis. It promotes glycogen synthesis and promote protein synthesis, and also promote uptake of ions, especially sodium and phosphate. Now, what does it stop? It stops glucogenesis in the liver. It stops gluconeolysis in the tissues. It stops lipolysis, breakdown of the adipose tissues, and it stops ketogenesis in the liver, and also glucolysis. It also stops that one. That is the simplest way the insulin works. That one, there is the one which it stops and the one which it promotes. So let us ask ourselves some few questions. Insulin level increases when glucose administered by mouth for food intake and glucose given IV. Glucose infusion, no difference. Now, the answer is A. If you take glucose orally, the body will produce a lot of insulin, but when you take into IV, there is not the same. If you have two patients or two study patients, one patient you give IV glucose, and the other one you give the same amount of glucose orally, the patient who is given orally glucose will do what? Will have a more level of insulin, and we will see that one just now. Now, what is this one indicating to us? So you can see this type of study which was done in 1986, where that there is insulin response in two types of administration, where that insulin was given at the insulin The bright one is showing that you give IV infusion of insulin, and you can see that the peak glucose, the insulin was 20, and when you give oral glucose, that is 50 milligrams, the peak was 60, around 70 at 50 minutes, and then it reduced and they were the same at 80 minutes. And the difference between the highest peak and the highest peak when you're giving orally and the highest peak when you're giving intravenously is what is called incretin effect. And because you remember that there is those drugs which works as incretin mimics, they are called incretin mimics, and that one there's a peptide which promotes enzyme which promote the production of insulin in the GIT. So that is the difference. So you can see that the peak, when you give a patient oral glucose 50 milligrams, another patient you give IV glucose 50 milligrams, after 50 minutes, you realize that the patient with the IV glucose will not, the insulin will not have produced enough glucose, and the other one will have produced glucose all the way to 70. And this is because when you give orally, it stimulates incretin enzymes which are which stimulate production of insulin, and that is what we call postprandial insulin. Now, let us look at this one now, diabetic and the incretin effect. Now, the first one is in a normal person. So let us see now this one in a patient who is diabetic and this incretin effect. So in a diabetic patient, ahead of the patient is that more than around 80 to 70 patient will produce insulin after being given 50 milligrams of glucose orally. And then the difference is very wide. You can see the normal incretin effect in the patient, that the patient, there's a great rate that a patient who is given IV glucose infusion is having around 20 in 50 minutes and that area. Whereas in a type 2 diabetes is that you see the comparison is that the incretin effect is reduced. Means that when a diabetic patient is given oral glucose and another one, and then at the same time patient, you are given IV glucose, the difference is small. Meaning that in type 2 diabetes, this enzyme called the incretin, its effect is reduced in type 2 diabetes. Now, let us see these classifications of diabetes. There are various around 8 to 10 classifications of diabetes, but let us look at these 4. The first one is type 1 diabetes, where there is no beta cells and the patient depends on insulin. Some literature will call it insulin dependency type of diabetes. Type 2 diabetes is another one where patient can take oral drugs, and the other specify like adulthood drained, the others as like Monday, others as LABA types of diabetes. And also there is another one when diabetes which is called type 3 diabetes, which is associated with the brain atrophy, or what is called vascular dementia and Alzheimer. Some people call it type 3 types of diabetes. There is also another type of diabetes which is called pediatrics type 2 diabetes, and also there is what is called gestational diabetes. Now, let us look at the first acute complication of diabetes, and this is diabetic ketoacidosis, which is a medical emergency. Principally, it is very common seen in type 1 diabetes, and it is high mortality because of cerebral edema. And you will see the reason why it has cerebral edema. It is very common in children and adolescents, and also in adult, it is very common, and in adult, it is associated with hypokalemia. Hypokalemia, you know that when you have hypokalemia, there is a problem of arrhythmias, and also it is associated with acute respiratory distress syndrome, and also comorbidities conditions like ischemic heart disease, renal diseases, or that of diseases. So let us see the pathophysiology of this ketoacidosis. In a normal person, there should be a balance between the glucose and the counter-regulatory hormones of glucose. And these hormones are glucagon, epinephrine, cortisol, and growth hormones. And also sometimes the thyroid hormones are also in this class of counter-regulatory hormones, which act against insulin. Now, in a DKA, in a diabetic ketoacidosis type of patient, there is no insulin, so there is excess production of these counter-regulatory hormones, which are what? Which are glucagon, epinephrine, cortical growth hormone, and also we have seen also another thyroid hormones also plays that role. So in this case now, you see that in a DKA, there's excess production of these hormones. And you'll see that what does this excess hormones of counter, which works against insulin, how they do and what do they do in the body? Okay. So in an insulin deficiency patient where there is no production or there is insufficient production of insulin, what happens? There is three pathways which are interrelated, which are followed in this case. For example, if there is reduced or no insulin in a patient, there is reduced uptake, glucose uptake, either by the tissues or by the liver, or the adipose tissues, or even the muscles. Now, this one results to increase glucose in the body, which is called hypoglycemia. When you check, the glucose is increased. Now, if there is excessive glucose in the blood, result to osmotic diuresis, because the RAS system, the kidney, the ejectocardiomedullary apparatus, and the denser will sense all these ones. And now the body will, the kidney will start now excreting a lot of glucose in the body. And this one, whenever the glucose, there will be needed a lot of water to excrete it out. So the patient will have to excrete a lot of water, which is going to flush out this glucose. And this one now, the patient will lose a lot of water in terms of urine. And also, you know that wherever there is water, there is what? There is sodium, salt. And this one patient will have dehydration and will have electrolytes loss. Specifically, the sodium is lost. The sodium is lost in this type of patient. Now, which can result to electrolyte imbalance and dehydration. You know that very well. You lose 1% of your body water, you feel thirsty, you lose 10% of your body water, you die. So the other pathway of lack of insulin is what? If there is no insulin, that means that what? The counter hormones provoke the process of the body starts producing what? The insulin, because the feedback in the brain is that the intracellular, that is the mitochondria, the powers of the cell, does not have enough glucose, but the body that is not aware that the problem is the gate, the entrance. So in this case, there is a conversion of a breakdown of proteins, and this breakdown of proteins result to amino acids, and these amino acids result to a conversion into glucogenesis and glycolysis, which result to what? Which result to increased glucose in the body. And this one again leads to osmotic diuresis, dehydration, electrolyte imbalance, and then dehydration, and then can cause also death. So again, insulin deficiency also excessive counter hormones, the cortical hormone, the epinephrine hormone, and the growth hormone, the glucagon, and also the thyroid hormones can also start promoting the gluconeogenesis, which can result to hyperglycemia following that route. On the other part, if there is insufficient insulin in the body, can result to increased breakdown of lipids, breakdown of lipids, and this one can follow two pathways. It can either this breakdown of lipids can be converted into glycerol, and this glycerol result to glucogenesis and increases gluconeolysis, and this one results to hyperglycemia. result to hyperglycemia, again following resulting to osmotic diuresis and the dehydration and the electrolyte imbalance. Now, on the other side, the glycerol is the one which causes glucogenesis. That one breakdown is converted into glucose. Now, on the other side, there is a lipolysis can result to free fatty acids. Free fatty acids, they are taken by the liver, and then there is what is called hepatic ketogenesis. There is a breakdown of these free fatty acids in the liver, breakdown of these ketones, and these ketones produces acidic ammonia in nature and results to metabolic acidosis. And this metabolic acidosis can cause hydrogen ions into the cell and it deplaces potassium out, resulting to what? Resulting to ketosis, to ketosis. So basically, that is how ketosis or DKA, diabetic ketoacidosis, comes about in a patient who has insufficient. And we have said that this type is also result in a type 1 type of diabetes. So what are the cardinal biochemical features of DKA? In DKA, the patient is having hyperketonemia, which is more than or equal to 3 millimoles per liter, plus ketonuria in the urine more than 2 positive on standard urine sticks. And also this patient will have hyperglycemia, that's blood glucose more than 200 milligrams per deciliter, that's more than that. And the metabolic acidosis in the venous bicarbonate is more than 15 millimoles per liter and more than a pH of 7.3. If the patient has the cardinals features of hyperketonuria, ketonemia in the blood and also in the urine, hyperglycemia, and the metabolic acidosis with more than 15 millimoles per liter, then you can see that the patient is having what? Is having a DKA. That is at a biochemical perspective. We look at as a clinical perspective. Now, let us see the clinical manifestation of a diabetic ketoacidosis. What is the clinical manifestation of diabetic ketoacidosis? Now, in diabetic ketoacidosis, it is very common in type 1 type of patients, type 1 diabetes, and we said that in this case, the 3 pathways, we will have to follow them, and then we see how these clinical features comes about. The patient does not have enough insulin in the body. There is reduced glucose uptake by the adipose tissues and also by the muscles and by the liver. So there is a lot of glucose circulating in the blood, which is called hyperglycemia. We check the glucose is high. Then this glucose in the blood circulation can result to osmotic diuresis because the kidney will activate the RAS system, assisting the kidney to clear out, flush out the glucose in the blood. Then this one will lead to what? A lot of blood goes to the kidneys, a lot of water passing out the tubules. This one will result to polyuria, a lot of urine taking a lot of water, and then because the water is excreted out together with electrolyte, it will cause electrolyte imbalance. It will cause electrolyte imbalance. So your patient will manifest with what? With polyuria, polydipsia, and the electrolyte imbalance. And in this patient, because of polydipsia, the patient will be dehydrated, the tongue will become dry, will have a tachycardia, the heart will be pumping very fast, and also the patient will have low blood pressure, and also will have abdominal pain. Will have abdominal pain. On the other side, the patient can have increased proteolysis, breakdown of the proteins because of insufficient iron and because of insufficient insulin. And then this is because of activation of the antagonistic types of hormones which works against the insulin, and we stop them like growth hormone, the thyroid hormone, the corticosteroids, the adrenal hormones, they will provoke this pathway. So if there is breakdown of proteolytic of these proteins, there will be production of amino acids because the main basic molecule of proteins is amino acids. So in this case, the amino acids will be converted into glucose by the process of gluconeolysis and glucogenesis. And this one again is going to lead to increased hyperglycemia in the body, resulting to these features of polyuria, polydipsia, electrolyte imbalance, all those. So on the other side, there is increased breakdown of lipids into either free fatty acids or glycine. And the glycine will follow the 5 years of hyperglycemia, whereas the free fatty acids will follow the process of ketogenesis resulting to lactic acidosis, and this metabolic acidosis, the patient will present with the fruity smell because of acetone in the mouth, and then sometimes we call it a sweet smell. The patient will have acidotic breathing, which is called Cushman breathing, and the patient will have mental status because of increased intracranial pressure because of osmosis, increased fluid in entering the brain because the sugar is entered, so the fluid has to go there to dilute there. So there is increased intracranial pressure. Now, so in diabetic acidosis, ketoacidosis, the onset is around 4 to 10 hours, and there is a history of lack of insulin, like GIT upset, like diarrhea, vomiting, or irritable bowel virus. The patient will have like a case of febrile illness, like dengue fever, malaria, all these type of things. Then the patient will have like a breathing, a smell like Cushman respiration, and that's dehydrated. That means the patient will have a juicy fluid gum. The patient will have tachycardia, hypertension, and acidosis. And when you check the sugars, is more than 24, more than 30, that is more than 30 millimoles per liter, or more than 240 milligrams per deciliter. The patient will have hyperkalemia and polyuria. The patient will have hyperkalemia or polyuria. So in this case now, what should you do? So in this case now, you should be ready to hydrate the patient, to give insulin, to correct the electrolytes imbalance, and also monitor the heart because of electrolyte imbalance can lead to what? To arrhythmias. So that is how you manage these diabetic activities. That's a summary of it. So let us look very detailed type of management of DKA. In a DKA, what investigation do? You take the venous blood, you look for urea, you look for electrolyte, you look for glucose and bicarbonates. And in the arterial blood gas, you assess for the severity of acidosis. In the urine, you check for the ketones, and also you check for ECG, and ECG so that you check whether there is arrhythmias. ST wave is the key ST wave. You check for ST wave if it is increased because of electrolyte imbalance. Then you do infection screening so that you look for the cause. For example, the patient had a febrile infection, the patient and missed the drug, or you can even check the urine if the patient may have a urinary tract infection. So you check for infections. For the cause, you check for this stress which is causing this patient to have this type of problem. So in the treatment is that you give a short-acting sodium insulin, you give fluid replacement, 0.9 milligrams of saline, sodium chloride, and give potassium replacement. You give sodium bicarbonate in severity acidotic patient. And if there's a presence of infection, you give the appropriate antibiotics. So what are the complications of DKA? DKA can complicate into cerebral edema because of rapid reduction of blood glucose, and this one results to hypotonic fluid, and the bicarbonate is what is used for this one. So the other one is acute respiratory distress syndrome, and also can result to thromboembolism because the lactic acidosis can stimulate the intrinsic pathway of inflammation by affecting the endothelial cells, resulting to production of prostaglandins, platelet activation factors, and also endothelin, and also heparin, and sometimes a small amount of histamine in terms of intrinsic pathway of inflammation. So it can also stimulate disseminated intravascular coagulation, and also can cause to acute circulatory failure. So let us look to the next type of acute complications of diabetes, and this one is called hyperglycemic hyperosmolar state. So what is hyperglycemic hyperosmolar state? Is occurs due to relative to insufficient insulin or inadequate fluid intake. So inadequate fluid intake. So what is the pathophysiology of hyperosmolar hyperglycemic state? So there is insulin deficiency in this type of patients because of various reasons, skipping injections. Then there's severe hypoglycemia. The severe hypoglycemia results in severe osmotic dehydrations. Then this severe hyperglycemia results to glucosuria, then osmotic glucosis resulting to polyuria. The patient will have a lot of polyuria resulting to polydipsia. And on the other side, because of severe hyperglycemia, there is breakdown of lipolysis without ketones. Ketones, in this case now, because there is no, it follows the pathway of glycerol instead of three fatty acids, and the movement of the liver. So there is weight loss. There is weight loss in this type of patient. So it is characterized by severe hyperglycemia of more than 600 milligrams per deciliter, and it is also characterized by hyperosmolarity of serum osmolarity more than 350 per kg body weight, and then it is also associated with dehydration in the absence of significant hyperketonuria or acidosis. So what are the clinical manifestations of these clinical conditions? The patient will come with the polyuria, weight loss, and the diminished oral intake of canotic orally profound dehydration, hypotension, tachycardia, and altered mental status, mental confusion, and and coma. So how do you manage this type of patient? You give normal saline osmolarity 0.45. This case now you can see that we are not giving 0.3, we are giving 0.5. 0.45 milligrams of saline, and then you replace with fluid electrolyte and loss, and then also you normalize the sugar, blood sugars by giving insulin. So the other condition is hypoglycemia. The leading cause of death in diabetes is hypoglycemia. It's another complications of diabetes in the acute phase. And in this case now, the patient will have hypoglycemia of sugars of less than 63 milligrams per deciliter in a diabetic, which occurs due to either the patient is injecting themselves a lot of overdose of insulin or hyperinsulinemia. The body is producing a lot of insulin in itself. So there's something called Whippur's triad. It is a symptom consistent with hypoglycemia, low plasma glucose concentration, and also relief of symptoms after plasma glucose level is reached. So in our day-to-day life, experience a lot of patients with hypoglycemia, either in the outpatient, in the inpatient, in the dialysis room, all these cases. So what are the causes of hypoglycemia? Is missed or inadequate meals, and unexpected or unusual exercises because of there is strenuous and consumption of a lot of glucose by the muscles. There's taking alcohol, errors in oral anti-diabetic drugs, not taking the drugs the way the adherence or insulin, dosage or administration, poor and disseminated side insulin regime or lipoatrophy at the injection of the site so that there is no proper there is excessive insulin intake. There is factitious and deliberately induced. Some people can deliberately do that one because of likely want to commit suicide, because a breastfeeding mother or who is diabetic also is also of course of hypoglycemia. So now let us see a normal person. A normal person, when blood glucose falls, what happens? In the three pathways, which at the end of the day, they result to the same something. So how does the body controls itself if there is low blood sugars? So in number one, it is that there is endogenous insulin released is suppressed. So if there's another place where the insulin was produced other than from the beta cells, it is suppressed, which results to reduction of the whole body glucose uptake and increases hepatic glucose production, which results to maintenance of the normal glucose supply to the brain. Now, there is a number two is the release of glucagon, which increased glucagon is the antagonism of insulin, and there is this which results to reduction of all blood glucose uptake and increases hepatic glucose production and maintains the blood glucose. The other way is that the autonomic nervous system is activated, results to release of catecholamines and the stress hormones are increased in the blood, resulting to reduction of the blood glucose uptake and increases hepatic glucose production, resulting to maintenance. So, so that is the way the body maintains its normal glucose in those three pathways if there is hypoglycemia. So in type 1 diabetes, you cannot regulate insulin once it is injected subcutaneously, so this one can result to hypoglycemia. So the moment you inject the patient with insulin subcutaneously, you cannot regulate it. So again, so this one can result to hypoglycemia. The key thing is you have to continue monitoring the blood sugars of your patient regularly, almost after every 15 minutes, and then you give them to take them with 50% with the 50 milligrams of glucose, so that you can be able to give this patient if the patient starts developing hypoglycemia. So, what are the symptoms of hypoglycemia? The symptoms of hypoglycemia is there are three. There's either autonomic way, neurogenic, and also non-specific. So there is this history of insufficient taking food, or most likely excessive exercises or excessive insulin, and the onset is 1 to 3 hours, and the patient will manifest with what? Anxiety, sweating, angry, confused, blood or blood vision, shaky, irritable, and cool, cramped skin, and the patient will require sugar increased as quickly as possible. So, in this case, how do we manage this type of patient with low glucose? So, in a mild cases, you can do self-treatment where you give oral fasting acting carbohydrate 10 to 15 milligrams is taken as glucose drink or tablets or confectory, or followed with a snack containing a complex carbohydrate. Then also in a severe case, if the patient is unconscious or unconscious, you give IV 75 milligrams of 20% dextrose, which and in children you give 0.25 grams per kg body weight in children, or you can also give IM glucagon, which is not available in our setup, so it is better you give glucose, and glucagon is not very common in our setup. So in children you give 0.5 grams of glucagon. If patient is unconscious and unable to swallow, you give oral refined glucose as a drink or as sweets. That is 25 milligrams. But you have to continue monitoring your sugars of your patient and also start establishing the cause of hypoglycemia. So, there's some things called dawn phenomena and smog phenomena, which occurs in our day-to-day life in our body. Every person has this one each and every day. So, like dawn phenomena occurs when there is endogenous insulin excretion and decreases, and the smog effect is seen when cases of excessive amount of exogenous insulin is produced. So let us see a smog effect. The smog effect is so much insulin. That was the reason why it was called smog effect. And there is too much insulin resulting to hypoglycemia, and then resulting to what? To glucagon release in our body. Glucagon release, and this one results to what? It results to lipolysis, breakdown of lipids, resulting to glucogenesis in the liver, and gluconeolysis, breakdown of glucoses. And this one results to rebound hypoglycemia and ketones, and this one results to ketosis. So that is what is called a smog effect. So let us see the Down syndrome, which is the down insulin. The Down phenomena is the body response to hormones released in the early morning hours. Counter-regulated hormones are released in the body, glucose level increases, and in the event there is an increase in insulin levels, so high glucose levels in the morning. And this is what you do in the morning about fasting blood sugars. So, in a smog effect versus Down syndrome, is that a smog effect occurs probably 9 a.m., 7 a.m. In the 9 a.m., the insulin will pack in the middle of the night. It's important to test blood sugar early in the morning. We may need it also to adjust the insulin doses. And is the 7 a.m., that is 9 p.m. in the evening. So in the morning is that 7 a.m. There is hypoglycemia in the morning. Hypoglycemia occurs in response to bedtime insulin. The body has a rebound effect of mobilization glucose, and the glucose in the morning, the blood glucose is 300 milligrams per deciliter. So in the morning, there is a headache, night sweats, and then ketonuria, and that's MEAS, and then the patient start feeling weak. So in dawn phenomena is that the blood glucose rises with the sun. As the sun goes, that is how the sugar started going up. In the morning, it is very small, and as it goes in the noon, it is high. So The growth hormones released during the night decreases the peripheral glucose uptake, causing the hypoglycemia. And here it comes the sun. The dawn phenomena takes place early in the morning with the rise of the sun, and rise in the blood glucose concentration occur into the hypoglycemia and during the night. So that is the smoke effect versus the phenomena, the dawn phenomena. So let us see the DKA versus hypoglycemia, hypoosmolar syndrome. And this type of cases that in DKA is that it is very common in children, whereas hypoosmolar hypoglycemia is very common in the elderly. Whereas DKA is very common in type 1, whereas hypoosmolar is type 2. In glucose, more than 250 glucose, whereas grams per deciliter, whereas more than 600 grams per deciliter in hypoosmolar. Ketonuria is very common in DKA, whereas it may not be there in hypoosmolar. pH, it is below, it is acidic in DKA, whereas it is alkaline in hypoosmolar. Hydrocarbonate, it is less than 15 in DKA, whereas it is more than 15 hypoosmolar. So osmolarity, serum osmolarity is variable in DKA, whereas it is in hypoosmolar, it is hyperosmolarity. So sensitivity to insulin is variable in DKA, whereas the patients who have hypoosmolar, they are very sensitive to a very small amount of insulin. So let us see the relationship between DKA versus hypoglycemia. So the causes of DKA is either insulin deficiency or increased counter-regulator hormones, whereas in hypoglycemia it is insulin overdose or hyperinsulinemia. Whereas onset in DKA it is gradual, whereas hypoglycemia it is acute. Symptoms and signs is that symptoms of DKA are hypoglycemia, dehydration, and acidosis, whereas the symptoms of hypoglycemia is brain glucopenia or systemic or sympathetic overactivity. Then random blood sugar is high in DKA, whereas in hypoglycemia it is low. Ketonuria is present in DKA, whereas it is negative in hypoglycemia. Ketonemia is yes in DKA, whereas it is negative in hypoglycemia. So when you give IV in DKA, there is no effect, but when the patient is given IV glucose, recovers very fast in hypoglycemia. So, in simple, is that stay super, eat healthy, beat diabetes. That was the name of World Day, Health Day 2016. Then beat diabetes, stay super. If in doubt, check your sugars regularly, and then beat diabetes by becoming active, and beat diabetes by following a prescription. So thank you very much for listening to this one, and I think it is very beneficial for you. You are going to assist your people and stop them from these acute cases of acute complications of